All right, good morning, everyone, and welcome to Cancer Center Grand Rounds. I'm really pleased today we have a exciting Grand Rounds on a topic that's relevant to all of us, regardless of the area of specialty. The title of the talk, I should say talks, is Innovating, Collaborating, and Moving the Needle for Comprehensive Fertility Preservation Care. And we have a triumvirate of speakers who'll go in sequence. The first is Kristin Smith, and I think anybody who's been here for any length of time has an automatic mental reflex when you think of fertility preservation to automatically think of Kristin and call her. And she's been here for a decade. She's the program manager for fertility preservation. The second speaker is Dr. Kara Goldman, and she's the medical director for fertility preservation, as well as having a role with their fellowship. And then finally, Dr. Emily Jungheim is professor in chief of reproductive endocrinology and infertility, and also, as an aside, married to one of our former fellows, Ken Carson. So I want to welcome all three of them, and we look forward to your talk. And I'd emphasize to everyone, they're going to go in sequence. We'll have questions at the end, and if you want to put those into the chat function, that would be perfect. Kristin, go ahead.
Thank you guys so much for having us all here. I am thrilled to be talking about fertility preservation with all of you on this lovely Friday morning. We have no commercial relationships to disclose. Dr. Goldman will be talking a little bit about some off-label usage, many of which you will all be familiar with. And as we go through this talk, we're going to kind of, because there's three of us, work in this sort of three-person fashion where I'm going to focus a little bit on the history and the access to fertility preservation. Kara's going to focus quite a bit on the clinical care, and that's kind of the meat of this presentation. And then Emily's going to talk a lot about where we go from here and what are some new ways that we can utilize innovation and things like that as we move forward with fertility preservation. And I don't think that we could talk about fertility preservation without talking about Teresa Woodruff, right? So again, for anyone who's been here for any length of time, we all know Teresa's name. Back in 2006, she applied for and received one of the most prestigious NIH roadmap grants for about $26 million to help push the science of fertility preservation forward. And in doing that, she coined the term oncofertility, which now is utilized really across the globe. And when she first started, she knew we couldn't do this alone at Northwestern. So she reached out to academic medical centers around the country, and we created what's called the National Physicians Cooperative. And this was a group of about 60 academic medical centers really around the United States and a couple up in Canada as well, where we kind of all banded together to, do different projects together. We were sharing research tissue. And then as we have grown and expanded, we've really seen this global need. And so now there is sort of this global network of providers called the Oncofertility Professional Engagement Network. And this has really opened things up to us and allowed us to start to participate in hopefully some more big data, if you will, so that we can really work with colleagues around the globe to ensure that patients really everywhere are having access to fertility preservation and that different centers kind of know where to go when they need help. And part of the Oncofertility Consortium here at Northwestern is that we have a hotline. And so I take phone calls and emails from providers and patients really all over the globe to help them kind of figure out where to go. And I do that based on this patient navigation model. And that's kind of how we set up things here. We felt that utilizing a patient navigator, which is what I was initially hired for, to be kind of the middle person, if you will. So, a patient navigation, if you're not familiar with it, was really started by Harold Freeman, who is a breast oncologist out in New York. And he felt that, a lot of his patients didn't have access to care. And by utilizing a patient navigator, that enabled patients to get from A to B to C quickly and seamlessly. And I think that's worked really well for us here at Northwestern to kind of utilize that model. And when looking at how things look at Northwestern, the way that we're set up is that, really, we are the middle people. So Bill's right. If you're thinking fertility preservation, our goal is that all you have to do is call me, and that we can then take care of your patients, ensure that they're seen quickly, seamlessly, that they can go through fertility preservation and then get back to their treatment with you. And I was thrilled that I was able to add an S on here to patient navigators, because we actually now have two of us. So it's myself and then also Jen Elvicus, who's a nurse. She's out in our Western region office to help support all the patients from the Western region. And we really do. We work kind of across all of these different specialties. So clearly within fertility and reproductive medicine, but then we also work with urology and help with sperm banking. On the clinical piece, obviously we work with you in the cancer center, but also within rheumatology and neurology for those patients receiving things like Cytoxan. And then we do go across the street as well and help out at Lurie Children's Hospital where necessary. Certainly on the basic science side of things, we work closely with the medical social sciences team, and then as well as the Oncofertility Consortium. And I think we all know that Teresa has now taken the provost job at Michigan State University. So that is a loss for us here for sure. Our goal and our hope is that, some of the clinicians and the scientists that are left from her lab initially, we will continue to push this science forward. And Kara's actually got some really exciting science that she's going to talk about in her part of this talk as well. So how do you get to me? Well, I joke sometimes that you can send me a smoke signal, but in the land of COVID, I'm not here necessarily 5 days a week, every single week. But you can always call the FERT line, which is 312-503-3378. I do also carry a pager. It's listed under my name. Just as a side note, there are two Kristin Smiths. We do share pages back and forth when we know they're for each other, but make sure you find the one under OBGYN. And then there is a best practice advisory as well. So you can do that within Epic. You can certainly send me an Epic message. We used to, and I'm sure many of you will remember, we used to have this stopgap question. And so that was something that Steve Rosen put into play, I think 11 or 12 years ago. And basically, when you had a new patient coming in who was of reproductive age, you had to answer the question, has the patient been informed about the impact their treatment may have on fertility? You could answer yes, no, or not applicable. When you answered yes, then a second question came up about, is the patient interested in fertility preservation? You could answer yes or no. And then you would get sort of my information to make that referral. That question was lovely because it really enabled us to dig deep into all of our reproductive age patients. When we went to the new Epic, if you will, this question has gone away and we have yet to figure out how to put it back within there. I do know it wasn't everyone's favorite question. I think when I started and I was about a year in, I do remember a provider who's no longer with us, but I will let you guess who it was, tell me that they thought that this question was witchcraft and that they hated it and they hated to do an extra click. And I know we all do a lot of extra clicks, but I think what I found from this questionnaire is that it really did enable us to say, oh, shoot, we didn't talk about it, no, but make the referral to Kristin and we'll get things moving that way. And, somehow, some way, hopefully we'll get some of these questions put back in Epic, but they're not quite there yet. In the meantime, please just remember to give us a call and we'll kind of take it from there. And then I wanted to share just some, I'll call it dirty data because it's out of an Excel spreadsheet that I've been keeping since 2010. It was started a little bit before me when we had kind of a part-time patient navigator back in 2007, 2008. But it's just, giving you a rough idea of how much we've grown in fertility preservation, just specifically here at Northwestern. And so, when I first took on this program, we were, in total on the female side, seeing less than 150 patients. And we've almost doubled that now that this goes into 2018. We're just continuing to grow. And that's in large part and thanks to you guys. When I'm giving lectures at outside centers or, talking to outside centers about starting their own programs, and they ask, well, how do you get your oncologist to make the referral? I'm like, I don't get them to do anything. They do it because they know that it's important. And I'm always toting how amazing it is that we have such phenomenal providers here who are thinking about fertility preservation when they're also having this patient in their room with an existential crisis. So, I want you guys all to know that this program wouldn't be possible without, all of your hard work as well. And we're so, so grateful to you. So this is the female data, again, very dirty, if you will, because it's just out of my little spreadsheet. And then on the next slide, you'll see the male data, which, you know, same thing. We've seen just continuous growth within both referrals and then access to fertility preservation. And then I want to chat a little bit about insurance, because in 2019 here in Illinois, we had a massive, massive win. Then Governor Rauner came to Northwestern to sign Illinois House Bill 2617, which in the state of Illinois, and including Medicaid, we are the only state to include Medicaid within this type of law. Insurances must cover medical fertility preservation. And since this law has gone into effect, we've seen the access to fertility preservation increase drastically. You know, it makes a huge difference when a 25-year-old who's just been diagnosed with cancer doesn't have to come up with a couple $1,000s out of pocket to freeze her eggs. When she knows that her insurance is going to cover it, she gets to make that decision based on medical need and not based on her bank account. And I was so thrilled and honored, I think, to be a part of that. I think it was definitely a different process to learn how a bill becomes a law. It was a lot of fun, a lot of amazing things came out of it. We're still working on some implementation specifically within Medicaid, but we're getting there. So, you know, I want you to know, if you do have a patient, there very well may be insurance coverage. It's not a guarantee that everyone has it. There are some caveats to that law, but we work really hard within the clinic to ensure that each patient gets their fertility preservation benefits verified, that we go through all the appealing processes with their insurance. We'll do peer-to-peers with the insurance to gain coverage for this. And then we do have very, very steep discounted package pricing specifically for our medical fertility preservation patients. And we work really hard to ensure that cost is not a barrier to our patients. So even if you have a patient that, you know, you think maybe won't be able to afford these services, please still make the referral, please still send them our way, because there are different grants and things that we could potentially tap into so that all patients have access to fertility preservation here at Northwestern. And then I wanted just to give a quick mention to the urology team. This is the team that helps out with our sperm banking. So when you refer a patient for sperm banking, they're often either going to see Josh Halpern, Bob Brannigan, or Valerie Brown within the urology department. I make those appointments. You do not need to worry about that. But we have them seen by urology so they can have a quick kind of history and physical done. The urologist will look at some baseline hormone levels. They'll make all the orders. And then the patient does bank downtown here in our fertility and reproductive medicine andrology lab. We freeze everything here and then it gets shipped to long-term storage at ReproTech. But in case you're seeing some urologists in some of your patient charts, I just wanted you to know who they were as well.
So at this point, this is Kara Goldman speaking. I am going to take over. Thank you so much, Kristin, for all the work you do and for just being such a beacon of this program. I'm going to start here with a little bit of background and a story. Everyone here knows, of course, Dr. Leo Gordon, and I have to kind of go a little farther back here and go back to 2004 when my mom was treated here in your incredible cancer center with Dr. Gordon for lymphoma. And this was my white coat ceremony. She started chemo the first week of medical school for me, and it was a really impactful time for obvious reasons. And it really, for me, developed my deep-seated interest in oncology and understanding the critical role that oncology plays with, the whole family. And I, had a strong interest in oncology at that point, but went into OBGYN and trained during my intern year at WashU with the incredible Emily Jungheim, who became a mentor and a friend and just an incredible colleague. And of course, Dr. Jungheim is well connected with this cancer center as well. And so to be here today speaking about fertility preservation and this incredible role of oncology and fertility and the way that these coalesce to take care of our patients in the most holistic way possible, it is incredibly meaningful to me. So just from a personal side, thank you for the incredible work you do and the impact you have on families. I'll be speaking about clinical care and within the context of fertility preservation. We know there are a vast array of indications for fertility preservation, oncologic indications for the patients undergoing chemo, radiation, transplant, non-oncologic indications for patients with autoimmune diseases like lupus, hematologic diseases like sickle cell, patients undergoing planned bilateral oophorectomy, those with diminished ovarian reserve or impending primary ovarian insufficiency, or patients who are seeking gender affirming therapy and preserving fertility prior to that. So of course, today we're speaking about oncology. And this is these are data that you are all very well familiar with, that there has been a steep decline in mortality among reproductive age women with cancer, thanks to the incredible work that you all do. And so we're seeing then a concomitant increase in survivorship within this cohort of women. And these are women who are seeking to go on to build families and have hopefully normal ovarian function after their chemotherapy. And so we have a real obligation to these patients to make sure that we are considering their quality of life after survivorship. And at the same time, we're seeing that women are delaying childbearing. And so this shows the mean age of first birth in the United States from 2000 to 2014. And we can see that the mean age has peaked in 2014 and continues to rise. So in 2014, the average age of first birth was 26.4 years, and that is even higher among college-educated women and in women in urban areas. And what this means is that there's an increasing number of women who are childless at the time of their cancer diagnosis. And so we're seeing the need for fertility preservation will just continue to rise as women continue to delay childbearing. In 1985, a physician, Fitzhugh Mullen, penned this paper in the New England Journal titled Seasons of Survival. He described his own struggle with cancer, his own diagnosis, and described 3 phases of survival: acute survival, which was the immediate diagnosis; extended survival, so learning to cope with and live within that diagnosis; and then permanent survival. And in this section of permanent survival, he describes reproductive health and dealing with concerns, including the frustrations of sterility, the risk of mutagenicity, and guidance on matters of adoption. And this is really fascinating because this was just 1985. It wasn't that long ago. And at the time, reproductive health was considered something that you just had to kind of cope with and consider adoption. And we understand now that if we were to write this paper now, reproductive health would have to be right under there with acute survival, with diagnosis, and immediately thinking about reproductive health, because now we actually have ways to address this. And the impact of cancer treatment on ovarian reserve, this is all something that I know this audience is very familiar with, but women are born with a fixed number of eggs. We have 1 million eggs at birth. And there's this progressive decline in reproductive function culminating in menopause due to this loss of the primordial follicle pool. And women exposed to radiation and chemotherapy have a far more acute loss of this pool of follicles. And unfortunately, the treatment regimens with the highest risk of reproductive toxicity are the ones that are used most commonly in young reproductive age women. So this is a table from Livestrong showing the risk of permanent amenorrhea post-treatment. Now, we understand that amenorrhea is a really poor proxy for fertility, but knowing that that's where a lot of this data comes from, with women treated with cyclophosphamide, essentially there's a extremely high risk of post-treatment amenorrhea. And, all of these treatment regimens here include cyclophosphamide. And so we know cyclophosphamide and other alkylating agents are among the most toxic and unfortunately very commonly used in this young patient population. This was a paper in the Annals of Oncology in 2006 looking at the risk of developing POI and infertility based on age and based on treatment regimen. And it illustrates what we know, that the greatest predictors of POI post-treatment are older age at treatment. So women over 30 had a greater probability of POI, and treatment regimen. So particularly regimens including an alkylating agent led to a higher risk of POI and infertility post-treatment. And in 2006, ASCO put out a statement instructing providers to discuss fertility preservation with all patients of reproductive age. And we certainly saw a rise in referrals at that time for fertility preservation and an increased understanding of the importance of fertility preservation. And again, there was another statement in 2013 emphasizing the same. But some of the data, not from our center, but from others, show that really only about 1 to 20% of patients who are eligible for fertility preservation are referred. Now, as Kristin said, I think that really does not apply here. I have been absolutely astounded in the year and a half I've been here at how dedicated the Cancer Center is to fertility preservation, very different from other places that I've trained and worked. And I'm extremely impressed. Clearly, there is significant buy-in here. Everyone understands the importance of this. But I think nationally, we could do a lot better in referring patients. And when we talk to patients, this is a direct quote that a patient told me. This was a 37-year-old patient who had an 18-month-old at home and was ready to start trying for her second child. She was still breastfeeding her baby and had a new diagnosis of breast cancer. And she walked into my office and said, this part is far worse than the cancer. And, not to over dramatize, because obviously survival and dealing with a cancer diagnosis is, there's nothing comparable to it. But from the perspective of these patients, the loss and the grief associated with their loss of fertility is really significant. And the data shows that grief from interrupted childbearing persists years after treatment, and it is only somewhat buffered by parenthood from adoption or non-biologic parenthood. And we know that regardless of what a patient undergoes in terms of fertility preservation, the counseling itself improves coping. So this is really critical, just to have that initial consultation, regardless of age, regardless of parity, regardless of if we think they're going to pursue it, just having the conversation helps. And it provides hope. So, patients will often say that the idea that someone actually believes they will survive to achieve parenthood gives them hope to get through their cancer. Patients often come back after their chemo, ready to start their family, saying that this was the thing that really kept them going. It was a powerful stimulus for recovery. And importantly, fertility influences cancer treatment decisions. So this was the Young Women's Breast Cancer Study. 620 women under 40 years of age, median age of 37, were surveyed, and they had newly diagnosed breast cancer. 51% expressed concern about post-treatment infertility, and nearly 1 in 5 considered rejecting, shortening, or changing their chemo or endocrine therapy to preserve long-term fertility. So women are really, they're really taking this into consideration when thinking about their treatment. The history of cryopreservation goes centuries back, but it's really only in the last decades that we've been able to apply cryopreservation to preserve fertility. So in 1953 was the first human birth from frozen sperm. In 84, the first human birth from a frozen embryo. In 86, the first birth from a slow frozen egg. In 99, the first birth from a vitrified egg, and vitrification is now what we use exclusively to freeze eggs. And in 2004, the first live birth from frozen human ovarian tissue. So this is all very recent history. And I'm going to go through some of the options for fertility preservation, starting with established and then evolving and experimental options. Established options, which I'm not going to be speaking about, really are in the area of gynecologic oncology, like fertility sparing surgery, ovarian transposition, for patients with cervical cancer, transposing ovaries out of the pelvic radiation field, conservative medical management. So for patients with endometrial cancer who will be undergoing progestin therapy prior to eventual hysterectomy. And then primarily talking about oocyte and embryo cryopreservation, which are established methods. Evolving methods, including ovarian tissue freezing, and then experimental, including pharmacologic fertoprotection. So when a patient is referred, as Kristin said, the kind of immediate next step is the patient has, receives their diagnosis, and then you and your team refer to one of our incredible patient navigators, Kristin or Jen, and then we see them as soon as possible after. So, at times, same day, next day, whenever we need to get them in, we get them in. The patient is counseled regarding the anticipated impact of their treatment on fertility and their options. And if they don't yet have a treatment plan, some of this is hypothetical, but we have a sense of what their treatment plan may be. Ovarian reserve assessment to understand how well they would respond in an egg or embryo freeze cycle, and if they are a good candidate. Now, even in someone who we may consider not a great candidate, we will offer the treatment unless the patient truly wouldn't respond to medication. Communication, of course, with oncology and determining medical eligibility. So in patients who have complicated medical histories, ensuring that from your perspective, the patient is safe to pursue this treatment. And then from the advocacy end, this is where Kristin and Jen work through applications to make sure the patient can get all the financial assistance they need, really focusing on the fact that we never want finances to be a reason a patient can't pursue this. And then the patient will start. And this whole timeline can be within, a day or two. And then the patient can start her medication, or we can spread this out over weeks, depending on how urgent the need is. But certainly for patients requiring neoadjuvant chemo, this can all be done within 24 hours. Let's focus now on this timeline between cycle start and egg retrieval to give you a sense of what's happening on our end once you refer your patient. So controlled ovarian stimulation, there are a number of protocols, but the most commonly used protocol is the GnRH antagonist cycle. And if we think about the menstrual cycle, we know there's one follicle that grows, that follicle produces estrogen, that estrogen thickens the lining of the uterus. Eventually that estrogen feeds back to the pituitary, we get an LH surge, and that's ovulation. And so what we're doing with controlled ovarian stimulation is trying to override the menstrual cycle and understanding these hormonal shifts, taking advantage of that. So we give much higher doses of follicle stimulating hormone to recruit multiple follicles instead of just one follicle. All of those follicles are growing. We're watching on ultrasound and checking with blood work to see how well those follicles are growing. We give a GnRH antagonist to prevent ovulation somewhere around day 7 of treatment. And then typically around day 10 to 12, once we've brought the patient in for monitoring every other day, we're watching very closely to see when the follicles should be ready, when there should be an oocyte inside capable of maturing. We give that final injection, and that is either HCG, which is structurally very similar to LH. So we're inducing the LH surge to get oocyte maturation, or Lupron, so allowing the pituitary to then release its own LH, or a combination of both. In cases where we are concerned about ovarian hyperstimulation syndrome, we'll preferentially use Lupron. And certainly Lupron is an excellent medication for this, and also prevents them from having a positive HCG screen if they were to then present for chemo in the coming days and be and have a pregnancy test. But in any event, the patient has their trigger shot. 36 hours after the trigger is the egg retrieval. The retrieval is performed under anesthesia in our procedure room, or if the patient is medically complicated or has a BMI over the cutoff that our anesthesiologists are comfortable with, we will perform the retrieval in the operating room. And I think one thing that really distinguishes our program is that we can take care of very sick patients. Many REI clinics are freestanding clinics with freestanding anesthesia, and they don't have the capacity to take care of very sick patients because they don't have the OR capacity. So it's really incredible that we can take care of patients here who are severely thrombocytopenic, who are very ill, and safely retrieve them. And the patient can, following their retrieval, go forward with chemotherapy as soon as necessary. We've certainly had patients go directly from our procedure room to an inpatient room to begin chemo. So whatever is needed from the oncology standpoint, we can accommodate. In patients, that previous slide showed kind of an idealized cycle where a patient shows up and she's day 2 of her period and ready to start her cycle. And historically, we would only start chemotherapy, or we would only start IVF cycles around day 2 or day 3 of someone's period, thinking that, we really had to take advantage of that wave of follicle activation in the early follicular phase. What we know now is that there are waves of follicle activation happening throughout the cycle, and a patient can start their stimulation at any point in the cycle. And so a patient, shows up mid-cycle right after ovulating and needs to start her egg freeze or embryo freeze cycle, we can start at any point and have equivalent outcomes. So that's called the random start protocol. And the patient will start at any point in her cycle. The other approach that we can take, and we're taking more frequently, is a back-to-back stimulation or duo-stim protocol, where a patient will want to proceed with stimulation immediately after finishing an egg retrieval to try to maximize her yield. So in someone who has the time, for example, a patient with breast cancer who is pursuing fertility preservation in the period between surgery and chemo, we can potentially pursue 2 cycles to maximize yield. And in just a bit, I'll go through why that may be necessary, because ultimately, the process of egg freezing is quite inefficient, and even a significant number of eggs may not yield a pregnancy. And so for someone who's really trying to maximize her yield, if we have your clearance, the clearance of her oncologist to proceed, we may consider a second cycle. And so the decision about freezing eggs versus embryos is a pretty nuanced decision, and we discuss a number of factors. So partner status, of course, is important, but I never want to make assumptions based on a patient's partner status. We have single patients who may choose to use donor sperm, patients in same-sex female relationships who may ultimately be using donor sperm in the future anyway, and who may want to expedite that process and find a sperm donor now. And certainly we have coupled married patients who, understanding that relationships can change, may choose to freeze eggs to optimize their own reproductive autonomy. There are psychosocial and legal considerations, knowing that the legal matters can get very complicated when we're dealing with embryos. And then prognosis. So, trying to ensure that the patient understands, what happens in terms of oocyte or embryo disposition in the event of their death. These are difficult conversations, but conversations we have with every patient. And in some cases, patients may feel more comfortable having only eggs frozen, to be less concerned about embryo disposition in the event of death. Religious perspectives. So of course, patients, some may be more comfortable with without fertilizing their eggs, and so maybe just freezing eggs from that perspective. And then yield and efficiency, which I'll talk through in just a minute. And of course, we all know these headlines of these patients who struggle to use their embryos in the future if one partner chooses not to use their embryos. Most states have laws requiring that both partners have to agree to be a parent in order to use embryos. And so in the case of a relationship dissolving, this can become really, really challenging. So the limitations of egg and embryo freezing, if we think about a hypothetical 35-year-old woman who freezes 10 mature eggs, when she comes back to warm these eggs, we know about 80% will survive, about 80% will fertilize, and about 30% will produce blastocysts. And this is data from my previous institution where we found that the blastocyst formation, so that development from that fertilized egg embryo stage to the final embryo stage that's ready for transfer, we have a bit of a hit in the embryo at that point, so decreased blastocyst formation rate. So we may only have 2 embryos at the end of this process, with beginning with 10 mature eggs. That same woman, if she freezes embryos and then comes back to thaw those embryos and use them, because of that 50% blastocyst formation rate, she may have 4 embryos to use. So there certainly is an efficiency issue, and it may be more efficient to freeze embryos, but that could be at the cost of reproductive autonomy. So it's really important to have this conversation with every patient. And then there's the issue of aneuploidy. We know that in a 35-year-old woman, there's probably only about a 1 in 3 chance of identifying a euploid embryo. And so ultimately this, 10 eggs in a 35-year-old may yield 1 or maybe no usable embryos. Looking at data from my previous institution, we looked at all of our thaw outcomes in patients who'd come back to use their frozen eggs after freezing before cancer diagnosis. The mean age of this population was 32 years. They waited about 2.5 years to thaw their eggs. Median number of oocytes thawed was 10. And at this point, when we published this, there were only 10 patients who'd returned for pregnancy, and the delivery rate per transfer was 44%. And so even in this young population, 32 years, only half of them had pregnancies per transfer. Now, some of them had embryos that were remaining to then go back and use for a second cycle. But I think the important point here is that this is not a guarantee, and we have to make sure to counsel patients appropriately. Long-term outcomes following cryopreservation. So these data on the left come from our institution. So these are patients who froze eggs or embryos, and then compared to those who were consulted and did not undergo freezing, there was no difference in cancer recurrence or mortality in this population with a 43-month follow-up. And the data on the right are very similar out of UCSF, showing that there was no difference in disease-free survival compared to those who did or did not undergo fertility preservation. So we have to be very clear and realistic about outcomes. Patients who freeze eggs and embryos have to understand that it certainly is not a guarantee. And again, because of this rise in aneuploidy and decline in live birth rate with increasing age, the likelihood of success with their frozen gametes is going to go down the older they are when they freeze. And data actually out of our center, Dr. Lawson, one of our psychologists, published that patients with cancer may overestimate their likelihood of success with their cryopreserved eggs and embryos. And there is some rationale here for the role of genetic testing of embryos so that patients have an understanding of what they have frozen before they start chemo. So we understand that patients need to be counseled about not pursuing fertility preservation, considering future donor egg IVF, or considering adoption. And then there are some unique considerations here. For patients with hormone-sensitive tumors, we can provide estrogen suppression with aromatase inhibitors, letrozole. And so patients are just on 5 milligrams of letrozole daily during their stimulation. This is something that I could probably talk for another hour about, and maybe we should have another conversation about. There are definitely advantages to this approach. It's not necessary, but some patients feel more comfortable feeling that their estrogen is suppressed. Patients with medical risks and comorbidities, we're worried, of course, in our cancer population about venous thromboembolism, those who are thrombocytopenic, making sure that they are safe to undergo retrieval, and then medical contraindication to anesthesia. So those who have a large thoracic mass, potentially, we need to be concerned about their safety for anesthesia. We can prepare patients if they need a future gestational carrier by doing all the FDA screening at this point, so they can use a carrier in the future. Those who have hereditary cancer syndromes, we can counsel regarding the use of PGTM, which Dr. Jungheim will be speaking about in just a bit. And then for those with post-treatment, facing post-treatment age-related fertility decline, all of our patients, of course, who are going to be treated with long-term estrogen suppression, hormonal suppression, will not only have the initial hit from their chemotherapy, but whatever delay in their childbearing because of their tamoxifen. And so for those patients, even those who are not going to be undergoing chemotherapy because of their prolonged tamoxifen, they may want to consider fertility preservation. And then we talk, of course, about gamete disposition in the event of death and possible posthumous reproduction. And then fertility preservation in minors and issues surrounding monitoring in minors, doing abdominal monitoring instead of vaginal ultrasounds, and issues surrounding consent and ascent. So to speak briefly about evolving options for fertility preservation, I say evolving for ovarian tissue cryopreservation. There was a statement recently put out that ovarian tissue cryopreservation was deemed no longer experimental. But I'm calling it evolving because given the current body of literature, there is potentially still limited effectiveness. It should be carefully, offered to carefully selected patients. We really only have about 140, 150 live births globally from ovarian tissue freezing. So while we know it works, there is a lot that still needs to be understood about the process. Now, ovarian tissue freezing is less applicable to the adult population. It's used far more frequently in pediatrics where there are no other options in pediatric patients who cannot pursue egg and embryo freezing. And in ovarian tissue freezing, there may be a limited role in adults. There are remaining questions surrounding slow freeze versus vitrification, freezing whole ovary versus cortical fragments, in vitro follicle maturation, and some work being done by the Loranda lab looking at bioprosthetic 3D printed ovaries, the optimal technique to transplant this tissue, and then longevity of graft function, because we are seeing that once these grafts are replaced, the grafts are very short-lived. And so essentially the ovarian tissue is replaced into the pelvic fossa typically, and there may be resumption of some ovarian function, but for a short period of time. And then I'll spend a little bit of time here talking about experimental options, and this is primarily pharmacologic ferto-protection. So when we think about fertility preservation, there's obviously the fertility aspect of this is incredibly important, but there's also hormonal function, and we don't have I think there truly has not been enough of a focus on the preservation of hormonal function because of the roles of estrogen in cardiac health, in sexual health, in bone health, in mental health. And this is a piece of the puzzle that's so important for patients and that we really don't have an answer for. When we're freezing eggs and embryos, we're freezing a very limited supply of gametes and embryos, potentially allowing 1 or maybe 2 pregnancies in the future. And of course, that does not affect their or does not protect their hormonal function. And it's important to think about the mechanisms of iatrogenic ovarian injury to think about how we can protect the ovary. There's prenatal loss of oogonia, direct loss of follicles, accelerated primordial follicle activation, which I'll be speaking a little bit more about, atresia of follicles, inflammation and damage to the stroma and damage to the vasculature. GnRH agonists are what we think of primarily when we think about pharmacologic fertoprotection. The preclinical studies in female mice show very mixed results, not surprisingly, in terms of their efficacy. So for every study showing that GnRH agonists protect the ovarian reserve in mice, there is another study demonstrating that there's no protection of quiescent and growing follicles, and that in vitro exposure to GnRH agonists does not preserve follicular survival. In rat models, similarly, very mixed results in terms of protection of the follicles versus no protection. And in primate models, there again is kind of an equivalent number of, there are equivalent number of studies showing protection versus no protection. And so this is exactly what we see in humans, right? So we have 30 plus years of clinical data in GnRH agonists, and despite so many randomized studies, we cannot definitively say that there is a benefit to fertility preservation. So 14 randomized studies in breast cancer show a potential prolongation of ovarian function and maybe a decrease in POI, primary ovarian insufficiency, but no clear benefit in fertility preservation. 2 RCTs in lymphoma show no benefit. 12 meta-analyses, potential benefit in preventing POI. There is a clear benefit in menstrual suppression in women who are thrombocytopenic at a bleeding risk. So from that perspective, yes, this may be protective of anemia and prevent menses, but we really truly cannot, rely on GnRH agonists for fertility preservation. And this is exactly what ASCO said in 2013, that it's imperative that we inform patients that there's insufficient evidence regarding the efficacy of ovarian suppression as a fertility preservation method, and they should not be relied upon to preserve fertility. NCCN said the same. And when we think about physiologic ovarian folliculogenesis, it makes perfect sense. The growing follicles, if you think about an oocyte is arrested at prophase of meiosis 1 in a primordial follicle. It grows to become a primary, secondary, and antral follicle, and these growing follicles are FSH sensitive. But the bulk of the ovarian reserve is in these primordial follicles, and this is the follicle and the oocyte that we need to protect and is not protected by GnRH agonists. And so the mechanisms of damage are vasculature, stroma, and primarily I'm going to talk about this concept of burnout, where these growing follicles are damaged. It causes this compensatory increase in primordial follicles, and then we lose the primordial follicle pool. And my work, which I'm going to go through pretty quickly because I want to leave enough time, of course, for Dr. Jungheim, is related to the mTOR pathway, which we know is critical to primordial follicle activation. So mTOR is a serine threonine kinase. It's a major metabolic regulator involved in numerous signaling pathways, regulating mRNA translation, cell growth, survival, and proliferation. It's really critical to primordial follicle activation. And we know that in murine models, upregulated PI3K and AKT results in follicular depletion and a POI phenotype. So we hypothesized previously that mTOR inhibitors could be used as fertoprotective agents, gave mice mTOR inhibitors, so RAD001, which is everolimus, or INC128, which is a dual mTORC1 and 2 inhibitor, and used these alongside cyclophosphamide, and found that in the mice that were co-treated with mTOR inhibitors and cyclophosphamide, there was downregulation of the mTOR pathway. So as expected, we saw downregulation of phospho-AKT, phospho-4-EBP1, and phospho-S6 kinase, showing molecular substantiation that these drugs were working as expected, and found that phosphorylation of 4-EBP1 and S6 kinase was decreased within primordial follicles after mTOR inhibition. So showing that within the follicle, we have decreased phosphorylation and so decreased activation of the mTOR pathway. And found that there were twofold greater primordial follicles in the mice that were co-treated with mTOR inhibitors alongside cyclophosphamide compared to cyclophosphamide alone. And AMH levels, AMH being the most clinically relevant measure of ovarian reserve, was significantly lower in cyclophosphamide-treated mice compared to those that were co-treated with mTOR inhibitors. So preservation of ovarian reserve. And ultimately, when we performed this study, and sorry about this formatting issue, but treated the mice with cyclophosphamide and then alongside their mTOR inhibitors, found that there were significantly fewer pups in the cyclophosphamide treated mice, and co-treatment with mTOR inhibitors resulted in a normal litter size. And these pups were normal weight, no anomalies. So this was very promising data. And this is a particularly attractive target because mTOR inhibitors are widely used for a number of benign and malignant conditions, as this group is well aware. They are FDA approved under the trade name Afinitor by Novartis for ER-positive, HER2-negative breast cancer in a subset of patients, advanced renal cell carcinoma, giant cell astrocytomas, tuberous sclerosis, and there's a lot of preclinical data looking at dual mTOR inhibitors as well. And of course, not to gloss over the number of downsides to using mTOR inhibitors, I completely understand the many side effects, and those could be certainly limiting, but this is an attractive area that we are investigating. And this sits within a growing landscape of pharmacologic ferto-protection, where mTOR inhibitors are one of many agents being evaluated to try to understand if we can use drugs alongside chemotherapy to protect not just fertility, but to protect ovarian function. And currently underway in my lab, I'm working on looking at the impact of mTOR inhibitors on the offspring. And so looking at the health of offspring and future fertility of offspring, both as a means of pharmacologic fertoprotection during chemotherapy, but I also have an interest in reproductive longevity in general. And so looking at these agents as possibly agents to protect and preserve reproductive longevity. And I think there's a really exciting opportunity to look at ovarian reserve and fertility in women treated with mTOR inhibitors. And so I'm always looking for others who may be interested in similar work and would love the opportunity to collaborate. And I'm now going to turn this over to my colleague and amazing division director, Dr. Emily Jungheim.
Thanks, Kara. That was really wonderful. And I'm going to I know that Dr. Goldman opened by sharing a story about how cancer and cancer care impacted her family. And that's where I'm going to continue our talk. We all know there are many ways to build a family. And in the reproductive medicine office, we're often thinking outside the box and helping patients who are faced with disease for whom traditional conventional paths won't work. So if we can go on to the next slide, as we all know, there are lots of folks who come to us. Can you go to the prior slide, Kara? So we all know there are lots of folks who are concerned about prevention of genetic predisposition to cancer. And Kara briefly mentioned PGT. So we'll go to the next slide. So pre-implantation genetic testing, what it is genetic testing of pre-implantation embryos. The first case of this was reported in 1990 for looking for Y chromosomes for X-linked recessive disease. And that's where this all started. So we'll go to the next slide. It was pretty inefficient initially, and now it's evolved where about 40% of all IVF cases in the country now involve genetic testing of the embryos. It's primarily done for aneuploidy testing, as Dr. Goldman mentioned. As we get older, the risk of aneuploidy in our embryos goes up, and oftentimes we need more embryos to work with. So why is it relevant in a cancer patient population? They may not have a chance to make new embryos down the road, so they may want to know what they're banking. So we can do aneuploidy testing for those folks, but we can also do PGT-M, or pre-implantation genetic testing for a single gene mutation. We'll go to the next slide. And the next slide. And the next slide. So what it involves is basically growing the embryos to the blastocyst stage, which is a day 5 embryo, where we remove some cells from the part of the embryo that becomes the placenta. That embryo is then frozen, and those cells are sent off for genetic testing. It can be done by next-gen sequencing. or STIP array. And I thought I'd just conclude with a couple of cases to illustrate where this technology can be applied. I saw a patient with a GATA2 mutation and myelodysplasia when I was back at Washington University. John DiPerzio sent me this patient. It was a 33-year-old man with a GATA2 mutation, and he had a child with a GATA2 mutation as well. He had banked sperm prior to a bone marrow transplant, and then him and his wife underwent IVF with PGTM for the specific GATA2 mutation, and now they have a healthy baby girl who does not have that mutation. The child that they did have prior to this procedure, again, had the GATA2 mutation, and she may be in need of a bone marrow transplant down the road. There were discussions about doing HLA typing and things for the embryos, but as Dr. Goldman mentioned, we're limited by the number of embryos that we have to work with. But those are things that can be discussed. The next slide is another case of a patient who came to see me with a variant of unknown significance in a P53 gene, newly diagnosed breast cancer, and she also had a brother who had passed away with a glioblastoma at age 25. In the research lab at WashU, his tumor had been sequenced and found it had the same variant of unknown significance in the P53 gene. And as we all know, we talk about variants of unknown significance, but as my husband reminded me, we're clinicians, and clinically, we knew that this variant was significant for this family. Ultimately, this patient did IVF with embryo banking. She did genetic testing for this mutation prior to initiating her breast cancer care. And ultimately, this variant of unknown significance had been described in other families as well, and now is known as a mutation. So those are just a couple of cases where genetic testing of embryos can be utilized for patients and families impacted by hereditary cancer. We do have a multidisciplinary genetics conference. It's bi-monthly in our unit, where if you have a patient who has questions about this, we'd love to have you reach out to us and let us know, and we can involve you in this conference and talk about what this family's needs are and how we might be able to help them. Next slide. Another piece that's being considered and discussed is the use of CRISPR-Cas9 technology. As Dr. Goldman mentioned, we are limited by how many embryos we can make. It's a function of patient age and ovarian reserve. And if we don't get that many eggs, unfortunately, there's not a whole lot we can do in being able to detect which embryos are safe and free of the mutation. But with CRISPR-Cas9 technology down the road, it may be possible to actually edit out the specific mutation that we're concerned about. So those are just some things that are being discussed in reproductive medicine and how we may be able to help your families affected by hereditary cancer, both now with PGTM and in the future potentially with CRISPR-Cas9. That's well away, but is certainly being discussed. For those of you who may be interested in learning more about what you can do on the oncology end for fertility preservation, there are some programs. There's the ECHO program, which is a web-based communication skill building training program to help oncology health professionals, social workers, psychologists, nurses, and physician assistants to communicate timely and relevant information regarding reproductive health to their patients who are needing these resources. And then also the American Society for Reproductive Medicine has some terrific online modules that are available as well. So with that, I'll conclude. Just a couple of things. We're located right down the street from you guys, around the corner. We also have facilities in Oak Brook and Highland Park for patients who may live out in those areas. And then I just want to highlight the picture in the upper right-hand corner. This is Dr. Goldman and the rest of our embryology and nursing team who do fertility preservation, do the surgical services to retrieve eggs and ovarian tissue, et cetera. This is them during COVID, working hard in the main OR to do an egg retrieval for a patient who needed more support in anesthesia care than what we can do in our local procedure room. So With that, I'll conclude, and thank you for your time, everyone. I would love it if you have any questions. Certainly, you can always reach out to us by email if there's anything we don't have time for today. Thank you.
Thank you very much, Emily, Kara, and Kristin, for a great talk. And it's great to know that you guys and your team are available to our patients. We don't have much time for questions. If anybody does have any, please send them via chat. But and they were making themselves available. If you have other questions, you know how to contact them. But one of the things that I just wanted to get a firm idea in my mind, when we see patients and they're young, we often refer them to you guys, and we're anticipating the start of therapy. So just so we're, as clinicians on the oncology side, giving them a good ballpark figure, because they're always concerned about the delay until they start their systemic therapy. What's the correct time frame we should be telling them that whatever maneuvers that you take, the delay should be roughly about how long? And then as a corollary to that, you talked about egg retrieval and, you know, the number and success. How often do you have to go a second time at that? Because that goes into figuring the start of therapy as well.
Sure. Yeah. This is Kara. I'm happy to answer that. So typically, you know, if we were to start a patient immediately, so someone who needs neoadjuvant, for example, like we could be done within 12, no more than 14 days. So, you know, at most, probably a 2-week delay if we start right away. And someone who potentially will need a second cycle, we could be done within, you know, 1 month. So kind of 2 cycles back to back. It's hard to predict who's going to need that second cycle. And ultimately, we never, you know, it really is a patient comfort issue. So some patients may feel good having frozen 10 eggs and say, I tried, I'm happy that I know that I've tried. Some may really want to look at the data and say, you know, I'm not going to be comfortable unless I have 15, 20, 25 eggs. And then they may feel more comfortable doing 2 cycles. So I think it's hard to give a kind of a set answer, but I think at a kind of minimum, probably 14 days for most patients.
And the other question, you gave the data on the LHRH agonist, which in breast cancer, you know, there's been data on both sides, as you pointed out. Is it your general impression or your general philosophy that we shouldn't be doing that? There's really no good reason to encourage patients to do that while they're concurrently getting chemotherapy as a way of protecting their ovaries?
I think there's not, I think the downside is the symptoms. So certainly the hot flashes, it's an uncomfortable medication. Patients don't like it, but they're probably going to be having those symptoms anyway. And so if there is any benefit, which there may be some benefit of prolongation of ovarian function, then I would say yes. I think the most important point, though, is not to rely on them for fertility preservation, which is obviously not a problem from your end. You all know that. I think the concerning messages in some places where they think that maybe it is a fertility preservation agent, it is certainly not. But I think I've certainly had patients who feel more comfortable being on it because they feel like they're covering all their bases and there's not a downside besides the symptoms.
And then finally, somewhat off topic a little bit, we do see these patients with metastatic disease who, despite, you know, we don't like to hit people with the sledgehammer on the reality of their diagnosis, but, you know, we try to lay out in a realistic way what they can expect. And yet some of them still want to go forward with preservation, fertility preservation, or thinking about pregnancy in the future. Some of those end up coming your way. What do you do with those patients?
It's a great question. And Dr. Gradishar, you and I share one of those patients right now, and it's really tough. I think that if the patient understands their prognosis and understands that they may be freezing but not able to actually achieve parenthood themselves, and they understand going into that process that they will be using a gestational carrier, they probably won't be parenting that child. I think, you know, we have that conversation, and that patient that you and I share is actually coming through right now interested in using a gestational carrier to achieve pregnancy. She has those embryos banked. And I think ultimately when it comes down to patient autonomy, and I think for some patients, they feel so strongly that they have to, that has to be a part of their life, that they have to have tried everything to be a parent. And even if they know they're not going to be carrying the pregnancy and may not survive to see that child grow up, it may be important to them. And that's where we have our psychologists very heavily involved as well.
And I just want to add on to that. It's a lot, oftentimes a couple, and they may have children already, and it's certainly tough, but we have more and more folks who are banking eggs or sperm or embryos and maybe not even have cancer, but something catastrophic happens. And those folks within the family may still choose to have a child with their deceased spouse. So, just to reflect back on the fact that in our office, there are lots of different pathways to building a family, and they may not be traditional or conventional, but in our office, these things are not uncommonly coming up.
Great. Well, thank you all three for a great discussion, and we look forward to working with you going forward. And at some point, we'll have you back to elaborate on so many of the things you discussed. Thanks again.
Thank you.
Thank you so much.
Bye-bye.